All right. Thank you. Thank you so much for coming tonight. And welcome to St. Croix County's second annual Mental Health Symposium. And before we get my name is Bob Rarrett, by the way. I'm the HHS Director, Health and Human Services Director for St. Croix County. But before we begin, I'd like to offer some thanks to Northwoods Technical College for providing this venue for us, to the River Channel for recording tonight's event, to Busy Bean for the refreshments out front, and our board members, committee members, judges, partners, and all of you from the public for attending tonight. Resource tables, you probably saw them across the hall there. I want to thank our organizations and partners who came tonight to set up those tables and provide information to you. You're able to go out there, you'll be able to go out there during break and after the symposium if you want to, and they'll stick around, I think, for a little while after we're done tonight. Each year, this is our second year for holding a mental health symposium, and this is Mental Health Awareness Month in May, so it's a good time to have this. Last year, our symposium focused on suicide in St. Croix County, and that work is continuing primarily through our public health department and our medical examiner's office in studying and understanding suicide deaths in St. Croix County and what we can do to help prevent those deaths in the future. It's ongoing work, and whenever we have a symposium like this, a different topic every year, the work doesn't stop after the symposium is done. We continue to do work to promote and try and make a difference in our communities for each of those topics that we cover, amongst other things that we do, of course. And tonight's topic is focused on addiction, substance use disorders. While last year's topic was focused on suicide in St. Croix County, this year's topic also relates to that. We'll tie those together as we go through year to year, and there's, health is integrated and interconnected, so all of these topics have some common ground. As I said, tonight's focus will be on substance use disorders and the disease of addiction. Our guest presenters and panel members will approach this topic from various perspectives, and our hope is to help you view addiction through a different lens, to better understand how the disease affects people, us as a community, and how we can respond. I'm going to make just a few introductory comments, and I'm going to turn it over to our first speaker, Dr. Anwar. But let me just try and set the stage a little bit for tonight and what we hope to accomplish. Addiction is a chronic but treatable medical condition that changes the brain in significant ways. The U.S. Surgeon General published an article on the neurobiology of addiction, and I want to just read an excerpt from that because I think it captures much of the theme that we want to adhere to tonight. So let me just read this quote real quick. Although the mechanisms may be different, addiction has many features in common with disorders such as diabetes, asthma, and hypertension. All of these disorders are chronic, subject to relapse, and influenced by genetic, developmental, behavioral, social, and environmental factors. In all of these disorders, affected individuals may have difficulty in complying with prescribed treatment. This evolving understanding of substance use disorders as medical conditions has had important implications for prevention and treatment. Research demonstrating that addiction is driven by changes in the brain that has helped to reduce the negative attitudes associated with substance use disorders and provided support for integrating treatment for substance use disorders into mainstream healthcare, end quote. A couple other points real quick. Addiction treatment has success rates similar to other chronic disease. Stigma surrounding addiction can prevent people from seeking care. And note that not everyone requires professional care to recover from addiction. We have our AA, Alcoholics Anonymous, Narcotics Anonymous, Al-Anon partners here tonight who have provided support for almost 100 years in our communities and online now for people to achieve long-term sobriety, and those supports are available and easily accessible by anyone. And I thank them for being here tonight. I wanted to mention that alcohol continues to be a major cause of illness and death in St. Croix County. Wisconsin is among the top 3 states for percentage of adults who use alcohol and substantially contributes to suicide, accidental deaths in St. Croix County. Our medical examiner's office reported that out of 43 unnatural deaths in St. Croix County in 2022, most resulted from accidental death or suicide. In nearly half these deaths, substance use was a contributing factor, with alcohol being the most prevalent drug detected. Most of these individuals were male, and most had a co-occurring mental health disorder. We're also experiencing fentanyl as an evolving drug in our state. Primarily, it's coming out of the Twin Cities, I think. Fentanyl is a powerful synthetic opioid that contributes to overdose death and is often mixed with other drugs without the person's knowledge. We do have medications such as Narcan that can reverse opioid overdose, and St. Croix County is currently distributing Narcan kits to really anyone. I think we have some in the room across the hall there, and you can receive a quick training on how to use it. They're nasal sprays. Anyone can have that. It's not going to hurt somebody if you give them a dose of Narcan, even if they haven't overdosed. And it's an easy way for us to, as a community, save lives. Any drug that affects the brain's reward system can lead to substance use disorder and significantly impact brain development in all areas of that person's life. It's especially concerning for younger people whose brains are still developing, and the frontal part of our brains continue to develop into our 20s. But for younger people whose brains are still developing, and that early onset of substance use can have a tremendous impact, not only on their brain development, but on the likelihood that they could develop a more severe substance use disorder later in life. For people with severe substance use disorders, obtaining the drug, including alcohol, can become their top priority as the brain perceives the drug as beneficial or even necessary for survival. It's an evolutionary trait where our brains perceive things that are rewarding as beneficial to survival of the species. And over time, that becomes ingrained in our brains in terms of how it perceives the benefits of that drug. Medication for some addiction disorders can help reduce craving, diminish euphoric effects, and strengthen recovery efforts. St. Croix County and our hospital and community partners are making efforts to improve access for these medication-assisted options like Suboxone, buprenorphine, naltrexone, and Vivitrol. I look forward to having you hear from our speakers tonight. We have some excellent speakers from a variety of areas that will give you a different perspective on addiction. Our hope tonight is not only to help define addiction for you, but it's also to provide a message of hope that recovery is possible. There's no wrong door to recovery. There's no prescribed series of events you have to follow in order to recover. It's up to the individual many times. And I'm going to let our first speaker, Dr. Anwar, who is Chief of Staff at Western Wisconsin Health and also a Health and Human Services Board member, come up and provide a little bit of perspective about addiction through the lens of healthcare. And Dr. Anwar, if you're ready, I'll turn it over to you. Thank you.
Thank you very much, Bob, and thank you to Northwood Technical College for having us here today. For those of you that don't know me, my name is Dr. Faisal Anwar. I've been in Wisconsin now for 6 years. When I first moved here from the East Coast, I signed the pledge to be a lifetime Badgers fan. I didn't, no other state told me to do that, but I never checked if that was true, but I did sign up for it. So I'm Chief of Staff at Western Wisconsin Health. I'm also a board-certified internal medicine physician, and I practice as a hospitalist or a hospital physician at Western Wisconsin Health. My wife, she's also a board-certified internal medicine physician. She's also specialized in transplant nephrology. We have 2 daughters, and we live in Hudson. Had I known kids were allowed, I would have bought mine too, Bob, along with me. So that's just a brief overview of who I am and why I'm here. I was voted into the HHS board last year, and I've been loving every minute of it. So I'm going to start my discussion by giving you a preface of what I'm going to aim to do in this discussion today. There will be a lot of overlap with Bob's presentation, but I'm going to try to minimize that as much as possible. So I'm going to start by defining what is addiction and what is substance use disorders. Who treats such disorders, and how can healthcare align addiction disorders more in parity with other chronic diseases, which I think we're not doing a good job of today. So how do you define something as broad as addiction? Well, I think the American Society of Addiction Medicine does a good job, and they have the qualifications for doing so. So my definition is not as long as Bob's, but it is shorter, and it is much more simpler to understand. They define it as a primary chronic disease of brain reward, motivation, memory, and related circuitry. And the two words I want you to remember from that definition is reward and motivation. That reward could be a multitude of things. It could be dopamine in your brain giving you positive feedback, and the motivation could be a type of learned behavior that causes you to get that reward. That motivation could be anything from tobacco, alcohol, it could be video games, internet, sex, pornography, shopping, binge eating. I could go on with that list, but pretty much anything, any type of behavior can become an addiction when it starts having an impact on your family life, your friend or social circle, your job, or anything in your domestic life. So pretty much anything can be an addiction, and we are all subject to becoming addicted at some point in our lives. There are no boundaries for addiction affecting males or females differently, addiction affecting different races differently, or your socioeconomic status making you immune to addiction. There's basically no discrimination with addiction. More than 7 million people suffer from illicit drug use disorder, and about 1 in 4 deaths can be in some way attributed to tobacco, alcohol, or illicit prescription drug use. So this is a big problem. The reason addiction gets a bad rep is when you mention addiction, based on our own biases, we have an archetype in our brain of what we think an addicted patient looks like. Everyone has a different archetype on what that patient looks like, but the truth is there is no archetype. It could be me, it could be you, it could be your partner, it could be your children, it could be your parents, it could be your colleagues. It could practically be anyone. And that stigma is what causes patients not to feel comfortable bringing it up, not only with their family, but also with their doctor. That stigma also keeps doctors from asking specifically patients about any behaviors that could be related to addiction or substance use disorders. So the stigma does go both ways, and it causes a delay in diagnosis. And a delay in any diagnosis causes a delay in treatment. So what I want you to remember from that statement is that it's not the patient's fault. It's not the patient acting out. It's because of their mind and their brain's response to the addiction cycle. So who treats this? There's a multitude of specialists that treat it. Behavioral therapists, psychotherapists, psychologists, psychiatrists. But we don't give primary care the credit that it deserves. Because when a patient does develop an addiction or a substance use disorder, they first are seen usually by their primary care doctor. And that primary care doctor could be family medicine, internal medicine, could be an urgent care physician, may even be an emergency physician if it's the first patient, the first type of physician that sees that patient. But primary care could be multiple groups of people. And the reason I single out primary care is because the diagnosis can actually start from that visit. And primary care, once they make a diagnosis, they can actually start treatment as well too. The problem that we run into is I also am a primary care physician at Western Wisconsin Health, and I'm allotted about 40 to 60 minutes for every new patient I see, or 20 to 30 minutes for a follow-up patient. I would say about half that time is spent in the waiting room where the patient waits for their appointment. The medical assistant rooming the patient, taking their vital signs, getting all their medical history and medical records, getting a list of their medications, seeing which vaccines they're due for, seeing what other healthcare maintenance they're due for, which could be anything from colon cancer screening, breast cancer screening. It's a multitude of things. And by the time they see a physician like me, I'm going to have less than half the time I'm allotted for actual face-to-face time with that patient. So I will also have to review everything that my medical assistant had done, review their medical history, review their medications for drug interactions, their allergy lists, their vaccine records, all their healthcare maintenance that they need. And ultimately, I may only have a few minutes to discuss their complaints, but even less time to discuss anything mental health related. That means addiction, substance use, and I'll tell you, just being honest, most patients will not be honest about their substance use. But they will be honest, or they have a better chance of being honest if they're asked about it by their physician. It's not something they will volunteer. And that's what makes it very important to give the time to addiction and substance use disorders from the primary care aspect. Even though we don't have time, we should at least take at least a minute here or two just to ask them the question, is everything going on with you, going okay with you? Ask them about their drinking, their smoking, their drug history, and just be upfront with it. Just say that addiction can affect anyone and make them feel listened to, not be judgmental. And a lot of times I find myself not talking to the patient about this, but just listening and giving them an opportunity to talk. And just those 1 or 2 minutes of silence is enough for most people to feel comfortable to mention that, hey doc, you know what, I have been actually drinking more often than usual, or I've been smoking more than usual, or I've been in so much pain lately, I couldn't see my other doctor in time, and I've been taking these other drugs that I got from someone else. And that's where it can start. Once you can make a diagnosis, you can start making treatment. You still need to refer to mental health. So you'll still have a role for psychologists, psychiatrists, and behavioral health, but there's a big role for primary care. And even after a diagnosis is made, sometimes patients won't come back to their primary care doctor about addiction treatment or substance use, and I think that's wrong because the primary care doctor may not have all the resources as a mental health specialist in treating these disorders, but we will be able to treat everything else. And there's another slide I'm going to show you later where that importance between comorbidities or other medical problems that a patient has are actually tied in with addiction and substance use disorders. How well a patient's addiction does or their substance use disorder does affects other medical problems they have. This could be diabetes, high blood pressure, any other medical problems. And how well a patient does treating their other medical problems also has an effect on how their addiction does as well too, or their substance use disorder. So the main point I want you to take from this slide is that we need to give more attention to addiction and other mental health disorders as we do to medical problems like high blood pressure, diabetes, heart disease. So let's review the definition of chronic diseases as the World Health Organization or the CDC defines it. And it's a very broad definition. The World Health Organization defines chronic diseases as being of long duration and generally slow progression. And their biggest list of chronic diseases starts with heart disease, stroke, chronic respiratory diseases like COPD or asthma, cancer, and diabetes. And they say that all of these chronic diseases combined represent about 60% of all deaths. Mental health is also in that picture. But if you read through the CDC and the World Health Organization, you'll see that they kind of stop short on calling addiction a chronic disease. There's language where they suggest it is a chronic disease, but when you look at how many resources are actually attributed to it, it's nowhere near these other chronic diseases. There's a lack of attention to it. So what is a comorbidity? A comorbidity is when someone has more than one disease at the same time. It could be diabetes and high blood pressure. It could be heart disease. It could be kidney disease. Interactions between two or more of these diseases have an effect on the other. So for example, if you're not controlling your diabetes well, you won't control your high blood pressure well. If you're not controlling your kidney disease well, you won't control those other two problems well. There's a mind and body connection, and that makes it even more important for addiction to be identified or substance use disorders to be identified and seen as a comorbidity, just like heart disease, cancer, diabetes. So we'll spend the most time on this slide, and this is what I want you to focus on. If you can remember one thing from my talk, is what can we all do in the healthcare field to make addiction more in parity with other chronic illnesses? How can we give attention to addiction and substance use that we give the same attention to high blood pressure or heart disease or strokes or heart attacks? We have to first start by breaking our own stigma on what addiction is and substance use disorder is. It's not something exclusive to a certain group of people. It's not exclusive to poor socioeconomic status. It's not exclusive to a certain race or gender. It could be you. You have to break that stigma, and you have to ask the tough questions, and you have to make time to listen to patients. You have to offer them reassurance that addiction can be treated, just like any other medical problem. You have to give them realistic expectations that addiction, like other medical problems, isn't a linear disease where you start at one point, you end at one point, and you go straight from point A to point B. There's going to be a lot of peaks and valleys. And there won't be considered a cure. A cure may be considered well-controlled, that you're keeping your addiction or your substance use well-controlled. Hypertension won't be cured. It's something that is well-controlled. Diabetes is well-controlled. We also have to identify that primary care physicians have to work with specialists in treating other comorbidities. There is an importance of primary care doctors to see any patients with addiction and substance use disorders, even if they don't have other medical comorbidities, because primary care also looks into preventive medicine. And so a lot of patients where their first exposure to the medical system is an addiction or a substance use disorder, they may not have other diagnosed medical problems, but they're at very high risk of getting medical problems, and that's even more important to be on time and see their primary care physician. And finally, we have to keep encouraging patients to keep seeing their primary care even when things are well controlled. Because reflecting back on preventive care, the primary care physician will be one of the first physicians to identify these problems. It'll be one of the first physicians that can help someone identify a problem before it becomes a problem to them. And the earlier you diagnose a problem, the earlier you can start treatment, and the earlier you can change the outlook and impact on their life. So that's all I had for my section. I know we will have a Q&A section at the end, and I hope many of you have questions to ask.
Thank you. Thank you, Dr. Onmore. Very nice. Thank you. Give us a second here to assemble our panel. We'll have a panel discussion next. I have to see how we're going to organize that, so let me go off the mic here for a second. One by one? Okay, we're going to do it one by one panel discussion. Let me introduce our first panelist here. Maggie, where are you, Maggie? There you are. I'm going to introduce Maggie. I'll let you introduce yourself, actually, and what you're here to talk about. Thank you.
Hello, my name is Maggie Whipple, and I'm the mental health navigator with Baldwin-Woodville School District. One of the things, well, first of all, I'll get more into my role a little bit later on the slides, but my main role is to get students connected in school and out of school with resources that support mental health. So we can advance. One of the biggest things that we as navigators in the district need to look at is the data. So I'm starting off with the data, which can be a boring thing sometimes, but the numbers can also shed a lot of light on what we need to work on and focus on. So a little history about the Youth Risk Behavioral Survey. It's put out by the CDC. The first one was given in 1991 to high school students. It has now since been expanded into middle schools. So it's given every other year. And they collected information from about 5 million high school students. Another thing too is, why do we have this survey? It's to help us understand the habits in students in regards to physical and mental health and behaviors. It also gives us a big picture for national, state, and local and emerging trends. It also gives us an idea on what we need to do as professionals in terms of program planning and help us monitor change. So when we think about schools, our youth in St. Croix County spend a good amount of time in schools. It can be a safe place for many. Sometimes students may struggle themselves, or they may have family or loved ones that struggle as well. and those behaviors can translate into schools. You can advance. Let's see here. It's why, going back to the Youth Risk Behavioral Survey, it is voluntary. Schools will often send out a letter that with opt-out options. So, and not every school takes it. That's another thing too, is we encourage we encourage schools to take it so we have a greater idea of what's going on in the county, in the nation, wherever it may be. So another thing, I wanted to pull up a few data points from the Youth Risk Behavioral Survey. The data that I have is from 2021, and it differs greatly from 2019. But one of the data points I wanted to bring up of the behaviors in St. Croix County, it's broken down. It takes the students about a half an hour to take this survey. There's questions on self-harm, anxiety, feeling sad or hopeless most of the time, considered a suicide plan or attempted suicide. There is a composite score that combines all those individual questions. And in St. Croix County, 54% of our high school students affirmed that one of those things was going on. It's an alluring number. Another thing I wanted to bring up too is 11% of our St. Croix County youth identify as LGBTQ plus, and those numbers are significantly higher when it comes to substance use and addiction and behaviors. Another thing I want to bring up too is another question on that survey has to do with self-harm or cutting. That is another addiction that we see high rates of in the schools. There are several reasons that this stat is important. We know that students will try and fix the situation on their own, and they may self-medicate and not reach out for help. And that's where we as mental health navigators come in to help build those connections of how these students can get help. Another thing too is some students may be struggling with breaking the family cycle of addiction. And so that might be a good time, in schools, they might find their safe person to talk to. Another thing too that we see with students is, and you might not think of this, is that when a parent or a loved one is going through something or going through addiction, there's some grief and ambiguous loss there, where the person may not have passed, but they are still around, but their parent or loved one is struggling and may not be there for them in the traditional sense. Some other stats that I kind of want to throw out there too, in terms of behavior, St. Croix County, 25% of students have tried a vape. 44% of high school youth have tried alcohol. 17% marijuana and other drugs and substances is 3%. So some pretty high numbers when it comes to St. Croix County. And this data is available online as well. So you can pull out the, I believe it's 159 pages of charts and data. It breaks it down by gender, LGBTQ, ethnicity, you name it, you can compare numbers. Sometimes I look at that and I can go down a rabbit hole and pull as much as much data as you want. You can find it in there. But it is also broken down into national, state, county, and then in individual schools. So yes, the next slide. How do we support our students? I think it's important that you get to know the people in your neighborhood, and specifically in schools. It's a team effort. We've got school counselors, nurses, social workers, psychologists, school-based mental health providers. That's where we have therapists come into the school to meet with students. We are lucky to partner with Western Wisconsin Health to see, to have those therapists come in. They're seen during the school day, about a 45-minute appointment, and they do connect with parents as well. So, and then there's also the mental health navigators. Now, this is a relatively new role. I was hired in 2019, and I was grant funded through the Wisconsin Department of Instruction mental health grant. And the reason is we were seeing more behaviors out of this youth risk behavioral survey. And the other thing too is when you have these people, you increase the support, or you increase access to care, and you help with early intervention, which we know with early intervention, there's better outcomes. And then it also reduces barriers. It gives you another avenue to go to connect with students. I was also going to make a comment on education and awareness. You know, the more we talk about it, and the more you get out and learn, the easier it's going to be to support our youth. And then despite, you know, growth in the mental health realm, there's still some challenges. There's still shortages, provider shortages, funding. There's still that stigma around it. And then there's the unknown. A lot of times we don't want to face what's unknown. So if you have any questions later on, please let me know. I do have more data points. I brought the whole St. Croix County packet with me of some of those stats. So, and it's, like I said, it's available online. And you can, schools are a little bit different to access, but the St. Croix County you can find on DPI website, or I believe you can find it in county CDC website as well. So I'm going to introduce our next speaker, Sophie Hansen. Let her.
Hello everyone, my name is Sophie Hansen. I am a certified peer specialist with Northwest, did I turn it off?
No, you're good. You just gotta hold it.
Hold it closer, okay. I haven't used one of these since karaoke days. It's been a long time. Hello? Oh, okay. All right. So my name is Sophie Hansen. I'm a certified peer specialist with Northwest Passage Transitions, and I do peer support with individuals in St. Croix County that are struggling with mental health and or substance use disorders. I work really closely with the behavioral health team here at the county, and I get connected to my peers through the therapists, social workers, substance use counselors, treatment court. Essentially anyone who's receiving services in the county can get connected to peer support. So what is peer support? The way I like to look at it is it's essentially one person having gone through a particular experience, helping another person navigate a similar experience. And I'm sorry, I talk a lot with my hands, so. But yeah, that's how I look at it, you know, and I believe that everybody here in this room has experienced peer support in their life, whether giving it or getting it. You know, if you think about maybe a challenging time in your life, it could be, you know, losing a loved one, or, you know, being a first-time parent, right? It's pretty natural for us to reach out to individuals in our lives that have been through a similar situation. You know, it kind of shows us that, hey, they got through it, I can get through this too. But it also offers like a different level of understanding and acceptance and empathy. So that's what I would consider like natural peer supports. In a professional sense, what I do in peer support is it's similar, but the issues or the struggles are surrounded around substance use and mental health. So what I do as a certified peer specialist is I utilize my lived experience with substance use and mental health as a means to connect with and support others that are struggling with similar challenges. You know, I like to believe that it really provides hope to people, you know, when they're struggling, and it also kind of, you know, it shows that recovery is possible and people can and do change. So a little bit about myself. I identify as a person in recovery. I started struggling at a very young age. I was in my preteen years when I first started abusing substances. That quickly moved on to you know, depression and anxiety and more substances. And I want to take a quick moment and just thank you, Maggie, for everything, you know, you just said, and thank you to all the other mental health navigators and coordinators and counselors and teachers. You know, because when I think back to 20 years ago when I first started struggling, we didn't have those kind of supports and resources and so on and so forth. So I'm just really grateful for that because that's a really vulnerable age. But yeah, I started struggling at a really young age. But something really instrumental happened in my life when I was, a few years later on in my teenage years. I went to my first AA meeting. I went to my first support group. And I'm going to be honest, it didn't cure me at that moment in my life. I still struggled off and on, but it gave me an opportunity to really start building my natural supports, my recovery, my recovery community. And I bring that experience into my work with peer support. I help my peers that I'm working with. I help them to build that recovery community, build that natural support network. I bring peers to, different meetings, and there's not just AA or NA. There's also Smart Recovery, Recovery Dharma, Celebrate Recovery, Dual Diagnosis Recovery. I mean, there's like a lot of support groups out there now. It's really a great thing. But in addition to going to support groups, there's also, faith-based supports. There's community supports. I have a couple of peers that are getting interested in volunteering in the community. In addition to all those like natural supports that people can have, and I help them on that journey, there's also clinical support. And I feel like that's really important as well. There's substance use treatment, medication-assisted treatment. I'm a huge advocate for that. There's therapy, so whatever path my peer wants to go down, I just support them on that journey. So, I have to use this. So one of the core competencies to be a certified peer specialist is to have knowledge in SAMHSA's definition of recovery. And I really just love this definition, and I thought this would be kind of a cool space to share it with everyone and kind of go through it and relate it back to what I'm doing in peer support. So SAMHSA's definition states that recovery is the process of change through which individuals improve their health and wellness, live self-directed lives, and strive to reach their full potential. I want to point out right away, it's a process, the first two words there. I feel like that's really important to acknowledge. Recovery is not a destination. It's a process. There's ups and there's downs. There's good days and bad days. It's typically nonlinear, just like Dr. Anwar said. It's important to acknowledge that, and something that peer support can really help with is, it helps build resiliency on those hard days while still celebrating with them on their good days. So improving their health and wellness. One of the ways I'm doing this in peer support is by utilizing, at Northwest Passage where I work, we have a wellness model. It's called the Passageway. So I go through it, and it has 8 different therapeutic elements of wellness. So when I'm going through that with my peers, if this is something they want to do, right, we'll go through that, and they'll identify, what are my strengths? Because it's really important to be strength-based, in peer support. That's really important. What are my strengths? How can I build off of those strengths? In addition to that, what areas can I improve on? How can I lead a more balanced and healthy lifestyle? That's the goal. So living a self-directed life. Another really important thing with peer support is self-determination. It's one of my favorite parts about peer support. The peers that I'm working with, they identify their goals, they identify their dreams, they identify, what path they want to take to those goals and dreams. I even have them identify how they want me to support them. I encourage my peers to be really, to be independent and to make choices that better align with their goals and their values. And I can kind of relate a little bit to my lived experience with this. And I know that, in my early recovery, or, whenever I tried to do things the way other people told me to do them, or if I tried to fit a box that others made for me, and it didn't result in lasting recovery. It wasn't until I really started building my own recovery and picking and choosing things that worked for me and building off of my strengths, really forging my own path, and that's when I was able to start thriving in recovery. So striving to reach their full potential. Peer support can really help people with doing, some self-exploration, and conversations, really just helping them paint a picture of what their full potential could look like. and taking the steps needed to reach that. I think it's really important too, just to note that not everybody is in a position in their life or in a space where they can paint a picture yet, or make those steps. A lot of the people I support are really struggling. I'm going to be honest. When I'm working with somebody who's in an active addiction or struggling with depression or other mental health concerns, I just sit with them, right? I support them. That's my job. It's called peer support for a reason. I give them a safe space to express their experiences and their emotions. I validate their experiences and their emotions. I feel like peer support's all about meeting people where they're at in their recovery. And I really feel that healing happens through connection. It happens through relationships. And at the end of the day, that's what peer support is really all about. It's about building healthy and supportive relationships. So what else do I have? Well, I do want to add one more thing. I work with a wide variety of people. It's adults of all ages, people from all different backgrounds. And I've met probably thousands of people on my own personal recovery journey. And if there's one thing I've learned on this journey or throughout my life, it's that addiction does not discriminate. It can happen to anyone at any time. And I think it's important to acknowledge that. And it's important to work as individuals and also in the community and as a collective to really do what we can to help reduce that stigma and increase the amount of support available, improving access to those supports. St. Croix County has been doing a great job with this, and I'm really excited to be part of this journey with them. And I just wanted to say, even us as individuals, we can make an impact in the world, so. I'm really grateful to be here today and to be a part of this event. And I feel really honored to do the work I do. So thank you.
Thank you, Sophie. We're super excited to have Sophie be a part of our team and bringing certified peer specialists into addiction care has been like filling a missing link, I think, in terms of the treatment system. Having someone that can listen and empathize with people who doesn't have the title of counselor, doesn't have the title of doctor even, but just can relate to them on a personal level in a professional way is an incredible asset. And we are actively trying to build upon the certified peer specialist role in our county so that we can include peers not just in addiction treatment but in other areas of healthcare, because I think they're vital. You're vital to what we do. And that was a really nice presentation. Thank you. Yeah. Oh, I have to introduce Phil. Phil Landgraf, Veteran Services Director. He's next.
Okay, I have to warn you, the last time that I did this speaking engagement in front of a large crowd, I found my wife, so I'm pretty good at this, okay? I'm really good at it. So, for those of you who don't know me, my name is Phil Landgraf, and I'm the Veteran Service Officer here for St. Croix County, Wisconsin. Don't know if there are any veterans here in the office or not, in the office, in the room here. If there are, maybe you would understand this a little bit more, but not necessarily just because there might not be a lot of veterans in the auditorium here. I don't think that you guys are, you can just breeze over this, because one thing with veterans, and there's a lot of pain, unfortunately, that comes with being a veteran and doing your job as in the military. And that pain can come in many different forms. It can come in physical pain, running, jumping, doing all the strenuous stuff that you can on your body. And with that comes a lot of aches and pains and things like that, things that can potentially deteriorate over time. Emotional pain. There's stresses that come with deployments and with waking up early in the morning, and with deployments also family matters as well. Very stressful and emotional issues that come with that. Also, one that's glossed over a lot is called spiritual or the moral portions. There's a lot of times that people have to do things while they're deployed that might go against a certain core ethics that normal people don't necessarily have to go through. Seeing dead bodies, killing, children. I mean, killing in general is just terrible things, right? So, I feel like it's always good to keep that in mind when you see veterans. Now, with pain, that makes people act and react differently. And I say react because in the military, again, there's a lot of things that are taught. They break you down to react. And that can come to a very much of a disadvantage when you come back into the civilian world and try to reincorporate yourself into what is normal or what is acceptable. So, just wanted to, there's also other triggers, but most of my veterans I see mask, and they mask their pain that they have gone through in their deployments or through their military service or past issues with alcohol and other drugs. I have some statistics as well. We'll get on that. So 22% of the OAF and OIF veterans with PTSD also have substance abuse. So you're talking about the comorbidities in there. I would also say I think that it's higher than that. Here's the reason why. Because 8 out of 10 Vietnam veterans seeking PTSD treatment, so those who are in 65 to 73 or thereabouts, have issues with alcohol abuse. So one could easily lead to the younger veterans are maybe doing a better job of masking those things or maybe hiding some of those things, but eventually they may come out, those who have PTSD. Also, half of those who have deployed need some form of mental health treatment. Only half of those who need the treatment will actually seek it. So there's a lot of people that are running around that might need some mental health counseling and they're not getting it. So one would ask, why would that be? Well, a lot of it has to go to the next slide, is the military culture that is very much known that the culture is very important that you surround yourself with, whether it be healing or what have you. Well, the military culture might have a few hiccups in it. We have a can-do attitude. We don't like to ask for help. There's a lot of stigma that comes with those things. And stigma is kind of a through line that I've heard through every single presentation thus far. So we don't want to be perceived as weak, or you don't want to potentially jeopardize your career. I have a unfortunate situation that I knew where there was 2 brothers that were serving. The younger brother who went into the military was killed overseas. The older brother had 10 years in service, and he was struggling a little bit. He said, oh, geez, but if he went in and sought treatment for that, he would have been pretty much not promoted. And his idea was he wanted to stay in for 20 years. Well, unfortunately, he got drunk, and he ended up beating somebody to a pulp to where he is now in a military jail, because what happened was he was trying to mask these pains that he was feeling from his military service and from the death of his brother. So I bring that up because, it's pretty extreme example, but those things do happen, and it's important to keep that in mind as well. So the third, or maybe second one on here, is there's a culture of drinking in the military. Binge drinking is it happens all the time, and we're very young too. When we're in the military, in between 18 and 25, generally is going to be where you're going to be, and drinking is pretty prevalent in those time periods. So tobacco use as well, very heavy, and in the military they also test for drug testing, marijuana and other drugs. They don't test anything for alcohol. So if you pop on a urinalysis for marijuana or something to that effect, that's a big deal. But if you come into a formation and you reek of Jack Daniels, which I have done many a times, you're not going to have any issues with that as long as you can make it through and run through. So the one other one that I want to talk about is boredom. When I went on my second deployment, I was 20 years old, and I was in Iraq, and I was in charge of 5 to 6 people. I mean, we were living life on the edge, and we were doing a lot of things that were really invigorating. I mean, you have so much adrenaline when you're doing some of these things. And when that happens, when you come back, there can be a little bit of, well, what's next? What am I going to do? How do I fill this knowing what you can do in life? How do I fill that void? And a lot of times, unfortunately, people fill it with some things that might not necessarily be too good for your long-term health. And then there's a lack of structure as well when people return. So I've been kind of going with a lot of the challenges that veterans face. But mainly, like I said, the main thing that I see in my veterans is an unaddressed, hold on, let me get you this. Main thing that I see is veterans is unaddressed issues that may have happened previously in their life that are unhealthy, addictions, and they form and they mask those. Then not only do they have the unaddressed trauma that may have been happening, but they also have the negatives that come with the addictions as well. So it's a dangerous recipe and often leads to financial and legal hardships that we see in our veterans. So, but the good news is that these things can be managed, and I know that we have a few success stories as well too. So that's all I have for now. Thank you.
Next, I'd like to introduce Dr. Phil Golly.
Good evening. How is everybody? Good. So I'm Phil Golly. I'm the Justice Services Director for St. Croix County. My department oversees the treatment court, the adult treatment court in St. Croix. So individuals that have documented drug and alcohol issues, but are also justice involved. So that's what I'm going to talk about, is kind of the intersection between those two. So that's one part of our department. And then the other part is pretrial services. So when individuals get in trouble or are charged with a crime, if they bail out of jail and are given conditions such as drug and alcohol testing or GPS monitoring, they see our team. So I'll talk a little bit about those two areas. I really do want to try to focus as much as possible on prevention and intervention, and not so much of the criminal justice reactive nature, but what can we do for when folks do become involved to prevent them from coming back into the criminal justice system. So again, as I said, for both treatment court as well as pretrial, we monitor folks' alcohol use. We have SCRAM devices or continuous alcohol monitoring devices that we use. So there's a compliance component to what we do, actually a pretty heavy compliance component, but we also do case management. So our team, we have 3 case managers in our pretrial services and 1 in our treatment court, and the idea is to refer to services. So if someone's struggling, what can we do to help them through, certainly in that moment, but for the future as well. And that really is the area that I want, and hopefully our department continues to work on, is that early intervention and then prevention down the road. I mean, we have that compliance component that we're beholden to as officers of the court, but what can we do to help folks cut down, or what we call desistance. So desistance from crime is ceasing criminal activity. It's a process very similar to recovery. Someone that is in the process of desistance doesn't ever truly leave a life of crime behind, but that's what we're focusing in on. A couple other things that are important to remember, and we do have a diversion program in St. Croix County. I'm not going to spend time talking about that because that program's housed in our district attorney's office. But something that is becoming very popular in across the country, and they're actually over in Dunn County, a couple programs that are referred to as deflection programs in law enforcement. There's both proactive and reactive deflection. So deflection with law enforcement, officers come in contact with somebody through a traffic stop, for example. Instead of entering that person or what we call inputting them into the criminal justice system, they'll actually offer them services. So if it's someone who is possessing a small amount of marijuana, for example, they can refer them to substance use treatment. So that's the reactive form. The proactive form is actually where law enforcement identifies what we call at-risk individuals. They go out into the community, and they go to their homes, and they go to their place of business, and they talk to them about that process of recovery. So these are some things that possibly in the future we can look at doing here in St. Croix. And then the idea of harm reduction. Certainly it would be nice if we could eliminate all substance use. That's the goal. But I think really to mitigate its impact on our community is where we need to start. That's it. Yeah, that's all I had. Thank you.
All right, we're going to take a little break here, and then when we come back, we'll have Pete Van Dusart speak. Thank you.
My name is Pete Van Dusart. I'm the Director of Behavioral Health for Health Partners Valley Hospitals and Clinics. So I work with all of the hospitals for Health Partners in the region. That's Hudson, Westfields here in New Richmond, Amory, and Lakeview Hospital over in Stillwater. I'm also the clinical supervisor for Programs for Change, our substance use disorder treatment programs. We have 3 of those, Hudson, Westfields, and Amory. And Wednesday night is my lecture night. So I'm usually lecturing in our treatment groups on Wednesday nights, and I lecture for 3 hours every Wednesday. And then Bob invited me to come and do 10 minutes. So I'm going to shift gears here. I'm going to talk really fast. I want to say that I agree with everything that Dr. Anwar said, except I did not sign a Badger pledge, even though I had 2 kids go to Madison. I am a University of Minnesota alumni. It's all right. I live and work in Wisconsin, but when it comes to Vikings and Badger and Gophers, I just tell people I was born that way. As most of us are. I'm going to talk about also Make It Okay. So Make It Okay is a program that was started a little over 10 years ago in coordination between Health Partners in Minnesota and NAMI. And NAMI is the National Alliance on Mental Illness. They got together because they wanted to address stigma about mental illness. And really the goal of that program is we need to change the narrative, need to change the way our entire culture thinks about, talks about, and deals with mental illness, which is a huge endeavor. If you think about it, trying to change something that is as old as people. People have had misconceptions and judgments and stereotypes and fears and superstitions about mental illness and what is it really and those kinds of things. And they decided to put together a program to try to reduce stigma. And the way they did that is they decided what we need to do is start talking about this, because the biggest problem for stigma is silence. People not talking about it, people being ashamed, people being afraid, people being embarrassed, or even people just trying to be respectful when someone is struggling with mental illness. In all ways, they go into silence, they go into quiet. One of the biggest challenges in really thinking about how stigma affects things is to think about that awful text or phone call you get in the middle of the night from the emergency department because somebody's kid was in a car accident and they're very severely hurt. And if you've ever been in a family situation or a friend situation, you got that call, you know all the bells and alarms go off and everybody just rolls into action. And that is, I got the kids, we'll cover the dog, do you need a car? Everybody rallies. The community just pulls together. They don't ask questions. The family's got enough on their hands, but they pitch in to help out. And the next day, it's lasagna, right? So you start making food and bringing it over, and you just step up. But what if that kid is in the emergency department because he's had a psychotic episode? And he's in the ER for 7 hours. First of all, you don't get the call, right? Because the family doesn't make the call. But guess what they need? They need the cars, the dogs, they need transportation, they need somebody to cover, they need people to help out. And then that person is admitted to a psychiatric hospital for 7 days. And the next day they need lasagna, okay? They need all of those things. And stigma is what prevents that from happening. Stigma because the family doesn't even make the call in the first place. They're embarrassed, they feel ashamed, they're worried about people judging them, they're afraid, they don't understand this, they have their own stigma, and there's even self-stigma. But let me take it a step further. What happens if that kid is in the ER because he overdosed, right? Or is going through withdrawal? What is the stigma about addiction? And stigma about addiction is, we have found stigma about addiction is even worse than stigma about mental illness. Because stigma about addiction is they've done it to themselves. Or it's a moral issue, or it's a character issue, right? Or it's even an intelligence issue. Or what they need to do is start living their life right, or just be smarter, make better decisions, get responsible, all that stuff. Let me tell you, addiction is a health condition about a pathological functioning of an organ in the body, period. All right? I'm saying stuff like this in front of two doctors right here. They're making me sweat here because I'm going to talk about psychophysiology in a real simple way. But basically, what happens in the brain, and I'm really glad you put up the slide about motivation and reward. It is these core moods and emotions that get affected by a substance that powerfully shifts those core moods and emotions. And for some people, that's powerfully reinforcing. Now, it might seem like the way it's reinforcing is that it feels good. On the surface, that's what it seems like it's about. It's usually not. You start with a person with a pre-existing horrible mood or emotion, like anxiety or depression or unresolved trauma or unresolved grief or low self-esteem. And that's their baseline mood and emotion. And then they take a substance that powerfully shifts that and makes it go away for a little while. How rewarding is that? Okay, that's fundamentally rewarding. So fundamentally rewarding that people feel they will use their drug or they'll drink and they'll say they finally feel like themselves now. How powerful is that? But that's not what causes addiction. You know what causes addiction? Repetition. Repetition is what changes the brain. It's how little kids, okay, I'm winning the race. I have 4 grandchildren aged 3 and under and a 5th one on the way. Huh? I am winning. And they are little experiments of learning, right? Constantly. How to walk, how to talk, all those things. And how do they learn any of those things? Repetition. You do it over and over and over and over and over again. And when you do it over and over and over again, I'm going to look at the doc again, okay? You build neural pathways that are then reinforced stronger and stronger. And that's a physiological basis for this repetition, for this powerful, what eventually becomes a compulsion. And once it's a compulsion, then we're talking about addiction, all right? And so it's that compulsion that has a physiological basis, okay? We need people to understand that, because if you're going to change that, you better identify what's really going on. And if you're going to identify it, it is a health condition. And I agree. Go to your primary care doctor. Talk about this. Over at Health Partners, we have a variety of different services that are integrated right into primary care. We have what we call integrated behavioral health, which is somebody who's in the exam hallway where you go and get weighed and all that stuff. We have one right there in that hallway then who can in real time address behavioral health concerns and then connect you to the other services, because it is a health condition. I firmly believe that. At the beginning, I got all kinds of stuff after my name. I was a licensed psychologist in Minnesota. At one time, I'm a licensed independent clinical social worker. I'm a director. What I usually don't put on my bio is that I was expelled from Hillsbury High School and forced into a detox. But I'm doing better. That was a long time ago. And here's the thing, I don't apologize for it. I got other health conditions too that have really impaired my life. I don't apologize for those either. Because when it was identified, I received treatment, I got better, and I moved on. Now here's the other thing. I'm getting way off my slides. You're doing great. Just stay right there, okay? I might get to them. I might not. Bob, sorry. It was all a ploy just to get me talking. Here's the thing I was thinking about tonight. Here's what I wanted to say. We don't talk enough about the people in recovery, right? I mean, you do any of these kinds of things. We talk about addiction. We talk about death. All that stuff, it's real. It's serious. We talk about the money. We don't talk about the people in recovery. In 2015, they did a meta-analysis study, and they tried to identify how many people in the United States are in long-term recovery from addiction, from all substances. They also tried to figure out how many people in the United States are currently active in substance use disorder. Active in substance use disorder at that time, 20 million. It's a lot of people. Long-term recovery, 22.3 million. And these are people who got better and put it behind them. Doesn't mean they got cured. What it means is they shut it off, they replaced it, which is what treatment is about. And when I say replace it, healthy, positive, effective, natural ways to deal with mood and emotion that are non-chemical. That's the key. And how do you get good at that? Practice and repetition. But once they did that, you can build neurophysiology for those coping strategies as well. And then you get a healthy brain. Now you still don't want to go back to using, but if it's functioning in this way, guess what? You made on with your life. You know, I was at a gas station. I got to be careful. For some reason, I go to gas stations, people go, "You're Pete, aren't you?" And I'm like, "Yeah." How'd you know? Right? And they're like, "I was in your program." I don't remember them sometimes. 5 years ago, 12 years ago, 15 years ago. And they're doing better. And that's what we're looking for. Well, that's the message I want to give off, is that that's really the goal. It's not just stop the dysfunction. It's about figure out how to be a healthy person and then get on. And here's one of my lines I use in my treatment program. Everybody in this room's got a bucket of dopamine on their shoulders. And when you use substance, all you're doing is manipulating the dopamine. When you stop using substances, you still got the dopamine. It's still there. And you don't have to miss out on anything, because you can now figure out healthy, positive, effective, natural ways to manipulate your dopamine to get high without chemicals, to have a blast, to relax, to cope with stress and anxiety, to deal with depression, to resolve grief, all of those things. Let's see what the next slide is. Oh yeah, there's some symptoms about mental illness, and then the next slide, symptoms about substance use disorders. Again, a malady that affects an organ in the brain, in the body, called the brain. Next slide. Here's the thing with comorbidity. So we talk about mental illness from no diagnosis or a mild diagnosis on a spectrum to very severe, very impairing kinds of diagnosis and symptoms of mental illness. But then we also have this spectrum where we talk about mental health. And everybody has a certain level of mental health, whether you have a diagnosis or not. And these are, your coping strategies, how much support you have around you, what you have learned about how to make sense of life, all of those kinds of things. And so it's a quadrant. And so the point is, you don't want to be down here where you have a serious mental illness and poor mental health. And you want to be up over there where you have less symptoms and much improved mental health, right? So it's a really nice way to talk about this. Click. Here's my animation. Look at that. But if you throw addiction on top of it, it complicates everything. Every quadrant is now worsened because substance use disorders is taking a substance to significantly shift mood and emotions. So it affects every quadrant because of your use of those substances. I can't take credit for that animation pretty good. I have a new word for behavioral health care. You ready? I'll unveil it. Go. That's all we're talking about, people. Be healthy. It's either you're unhealthy or you're healthy. And go to your primary care doctor. Like I said, we have these different services, and our services is one of what we teach is those skills, those abilities to deal with mood and emotion in healthy, positive, effective ways, and how to practice them. That's what that's about. Next slide. Make It Okay is about reducing stigma. I'm almost done. So Make It Okay is this program that anybody in here can participate in. I got a table out there with the green things and a little button, all that kind of stuff, or you can go to the website. But here's what we do. We train anybody to be a Make It Okay ambassador. And once we put you through that 2-hour training, now you're an ambassador. You don't get a tiara, I was hoping, or a sash, but you are an ambassador. And once you're an ambassador, anybody can do presentations anywhere. And they're going on all over. And by the way, I got invited to speak at Camp Ripley about vets and reducing stigma in the military. Fascinating. I was very honored to do that. But anybody, anywhere, can become a Make It Okay ambassador and then go out and do those kinds of presentations. So consider that if you want. The cool thing is we got all the materials, the slides and the swag and then and when I was at that thing, I said, in 10 years we have trained over 500 ambassadors for Make It Okay. And then the person who was assisting me afterwards said, man, you screwed that up. We've trained over 5,000 people to be ambassadors. And it's gone across the nation now. So if you want to do that, find out about the Make It Okay stuff too. Next slide. I'm done. Thanks, everybody.
All right, so note to self, give Pete more time at their next conference. Thank you very much, Pete. Very good. It's my privilege right now to introduce Judge Nordstrand. Sure. Thank you, Judge.
Well, I've got a lot of props, so I'll set those out first, and then we'll get started talking about something I don't do in court a lot. First of all, my name is Scott, and I'm a recovered alcoholic. So I see there's a few members of our group here, so that's good to hear. Are you hearing me okay? Okay. I'm not only a recovered alcoholic, but I'm your treatment court judge in St. Croix County. I'm the circuit judge in Branch 1, and I see a lot of trouble. Oh, stand closer to the podium. All right. It's not in my nature. Following rules, I guess we got to follow rules around here anyway. So what I want to do tonight is a little something different. I want to tell you a little bit about my story. I want to tell you a little bit about my friend Paul. There he is, who was my sponsor in AA. He's passed away now, but he was the guy who brought me to the recovery path. And then I want to tell you a little bit about what's going on in our courts now and the trouble that we see in St. Croix County. So first of all, I grew up in Hudson, Wisconsin. I graduated from Hudson High School in 1976 in that very gym where we had that inspiring and awful funeral this week. I was thinking, I don't know if I've been back there in 40 some odd years, but that was the place. And I went off to Alaska after I had gone to law school. I became a lawyer, and I went off to Alaska, and I practiced law there for 20 years. 15 years as a regular old law firm lawyer, and then 4 years working for the governor of Alaska, a guy named Frank Murkowski. His daughter is now a U.S. Senator. Anyway, I got a chance to do a lot of interesting things as a lawyer in Alaska, and I learned along the way how to be quite an alcoholic. That was one of my skill sets. It came on fairly slow. My family doesn't have a history of that in particular, but I learned through that repetition behavior, and I got that change in me. As I came toward my end of my time in Alaska, my time came to a rather abrupt end when the governor I was working for lost his election in favor of somebody you've heard of, Sarah Palin. Perhaps you've heard of her. In any case, I came back, and I realized at that moment in time I needed to do something about my alcohol abuse and use. It was getting out of control. It was changing my life in negative ways. And so I flew back to Wisconsin or Minnesota, and I went to Hazelden at Center City, Minnesota. And I went through the 30-day program. And I thought I learned a lot, and they gave me this book. This is the one I got when I came in, all right? Anybody who's been in treatment knows that's how you put your name on your book when you go into treatment, so you know which one is yours, and there it is. And I went to treatment for 30 days. I was a great student. I'm a lawyer. I'm pretty smart. I got it all. The counselors were so frustrated with me at sometimes I was helping other people. And they banned me from helping other people for a period of days because I wasn't focusing on me, I was focusing on other people. Well, I got out of Hazelden and I flew back to Alaska. I kind of thought I might continue on somehow up there. I had an apartment. Within a week I was drinking, and I was laying on a mattress on the floor drinking myself silly. Somebody, my family, my mother, decided to help, and they poured me on a plane back to Minnesota, and I went back to Hazelden. Now, here's the thing about Hazelden. Good place, Hazelden Betty Ford now. We all know about that. But they don't really expect to see you back in 2 weeks. And honestly, they don't really know what to do with you when you come back in 2 weeks. And the way it works is you live in units. I lived in the Shoemaker unit, named after Reverend Shoemaker, one of the philosophical founders of AA. And so I come back, I come in the door, they bring me in, and they put me back in the Shoemaker unit. Well, half the guys that were still there, when I left. Now that gives them pause too, as you might expect. Why is this guy back? So they had to figure out what to do with me, and so ultimately what they did with me was they sent me to the Dan Anderson Renewal Center, which is like their continuing education place, and they put me in this program where you went through the 12 steps over and over and over once a week with their actual big book experts. Okay? For those of you who are not well-schooled in this, this is the big book of Alcoholics Anonymous, published in 1939 by the first 100 members of AA, most principally Dr. Bob and Bill W., the founders. Well, so I learned all about these guys for 3 weeks, over and over. I went through it 3 times. So I had all this knowledge. And then I decided to come back to Hudson. Alaska wasn't for me anymore. I stayed sober for a few months, and then I started drinking again for the last time. And I remember to this day, like all good alcoholics who are in recovery I remember laying on that bed, drunk, wondering if I could ever stop drinking ever again. And I didn't have a lot of hope. And then my uncle, some of you have heard of him, Bert Nordstrand, he built a dog track in Hudson and lots of different things. He's in recovery. I didn't even know that at the time. He called me up and he said, Scott, I'm taking you to the retreat. This is a place in Wayzata, Minnesota, where they take you through the 12 steps the old-fashioned way. And I actually met a guy there. So I'm going to move for a minute. Here we go. And there he is, Paul Hilton, my sponsor. He used to teach there. He actually started the program, the Lodge program at Hazelden, and I was lucky enough, one day he was volunteering and teaching, and he came to the retreat. And he was talking about the 12 steps in a way that just resonated with me. He's a lawyer from Cumberland, Wisconsin, okay? So he's a lawyer. That kind of made sense to me. And he started talking about these 12 steps, and it made sense to me, as I said. And when everybody had gone from the room during a break, I said, Paul, this is great stuff. I remember this from my time at the Lodge program at Hazelden. He said, I'm not surprised. I started the Lodge program at Hazelden. And then he told me, and I wrote this down in my book, June 4th, 2007, at 2:10 p.m. at the retreat, I told him, I learned all that at the Lodge, Paul. And he said, you learned it all up here. You have to act. This is a program of spiritual action. And that was my moment. Everybody in this program has a moment when recovery becomes possible. And that was my moment. All right? And so we started a process together. He took me through the 12 steps. And over time, he used to teach all over the upper Midwest, teach the 12 steps. He taught me a bit about the 12 steps. I now teach the 12 steps at various groups over in the Twin Cities. Tend not to do it over here now because there's a lot of folks that I see in court that I would run into. But nonetheless, we wrote a book together. There it is. And you're welcome to have one if you'd like. I brought some. And it's about the 12 steps. A practical guide to the 12 steps of Alcoholics Anonymous, written by Paul H. and Scott N. And I bring this up not because I'm trying to push the 12 steps over anything else there is out there, all the other forms of treatment. And if you know enough about AA, you know they're not against anything else. In other words, that's the beauty of the program. They love all other efforts to get people sober and to stay sober. It's just a way that works. It's one of the most popular books that's ever been written in terms of publication. 40, 50 million copies sold worldwide. And I just think that it's something that we don't talk about enough. One of our speakers just a moment ago was talking about the people in recovery. Think of all those people that are going to the meetings. I got a copy of the meeting list here out in the hall. And a lot of people don't have the capacity to go to treatment. They don't really have the ability, for one reason or another, to sign up with Pete. And it may be because they don't have insurance, they're scared to do it, they're not likely to do it. Stigma could be a lot of things. But one thing we can ask people to do is to go to a meeting. Listen to some people in recovery. Some of them will have been to treatment. Some of them will have been to treatment there at HHS and else, or they're in treatment court with all of us. But we have this resource in our community all over, everywhere. Right now, today, at this very moment, I guarantee you there's an AA meeting or NA meeting going on in St. Croix County somewhere. And that's the beauty of that program. So, and I like to, we've got people in treatment court that we make people go to support meetings, and they can pick what kind of support meetings they go to. That's fine. It just so happens there's a lot of these. And so we use these programs very much. You know, if I had more time, what I do now as a recovered person, one of the things I do is I teach the 12 steps, as I said. It's one of the things I love the most to do. I take people through the 12 steps in various groups over in the Twin Cities in about 2 hours, an overview of how it all connects together. And someday maybe I'll start that around here, because I just love to teach the beauty of the 12 steps. The idea, and I'll give you the short version of the idea. We addicts and alcoholics have a physical problem. The doctor's opinion in the big book called it the allergy. But basically what it means is when we take a drink, we don't know what's going to happen. A normie knows what's going to happen. They're that person with that half a glass of wine sitting at that table when they leave the restaurant. I don't know how the hell they do that, but they do. That's a normie. I'm not a normie. And so we have a body problem that when I take that first drink, I don't know what will happen. I don't know how many drinks I'll have. Then we have a mind problem. The mind problem is that even when we're sober, when we're not taking that first drink, we talk ourselves into thinking that we really don't have a problem. Okay? My friend Paul, one of the most famous lines from his teachings was, he called it the itty bitty shitty committee in our head. And it's always meeting and it's always voting to take that first drink. And that's who's up there. But the beauty of the 12 steps is that there's another problem we have to address, and that's the spiritual problem that we all have. Addicts and alcoholics have the physical problem and the mind problem. But everyone in this room, everyone in this county, everyone on this planet has a spiritual problem. And the 12 steps of Alcoholics Anonymous, steps 4 through 9, teach us how to experience a spiritual change. And what the 12 steps teach is that once we experience that spiritual change, God will remove the obsession, the mind problem, automatically, with no effort on our own. And it sounds crazy. How could that possibly work? Well, it's worked for millions of people. Again, not to be critical or of any other kind of recovery, but I just want you to understand that there's a lot of people out there, millions of people, that have adopted this way of thinking about recovery and have achieved recovery together. So that's what recovery looks like in the 12 steps. And remember, too, the 12 steps isn't about going to a bunch of meetings. You know, there's the people that aren't in the recovery community, the 12-step community, they kind of think of AA as people who go to meetings. You know how many times the big book talks about going to meetings? One time. One time that they periodically had a meeting once a week for newcomers to attend, and it was open to anybody interested in a spiritual way of life. In other words, not just addicts and alcoholics, anybody. So that's kind of interesting. The big book isn't about meetings. The big book is about taking the 12 steps of Alcoholics Anonymous, steps 4 through 9, to achieve a spiritual change that allows us to have the obsession to take that first drink again removed. Now, I know I sound like a Baptist preacher, and I'm a Baptist by trade anyway, so I understand that. But I just wanted to do something a little different tonight to give you a sense, for those of you who aren't familiar with the 12 steps. If you want to learn a little bit, you can have a book. Okay, this is our little book, because nobody wants to read this book from 1939. I know it's hard, and so that's why Paul and I put this together as a way into the big book. Okay, so the last thing I want to tell you about Paul is he made me make this book this small, because he wanted it to be something that would fit into the back cover of the big book when you went to a meeting. That's why it's that small. Because he was committed to the idea that this wasn't a replacement for, but a way into the big book for those who wanted to learn about it. And so again, I'd encourage you to look into the 12 steps, find something out about it, and refer people who you think might need some help. Have them go to a meeting. It's not hard to do. Or see Bob, or see Pete. Now, the last thing I want to talk about before I'm done is the state of the courts and what we're seeing. And I want to tell you, I had a god-awful day. I don't know if it was because this was happening tonight, but here's my intake list from 1 o'clock today. I'm on intake. Now, and that isn't even that long a list, but I'm telling you, intake starts at 1 o'clock. For those not familiar, what that means is the people who've been arrested, who are in custody for a criminal offense, who need to come before a judge for an initial appearance and setting a bond, the terms of release, and all of that. I had so many addicts and alcoholics in today, you would not believe it. Meth trafficking, meth possession, various methamphetamine. I would say half of these cases are meth. Okay, St. Croix County? Half. You know what the other half are? Alcohol. You know how many aren't about alcohol and meth and some other kind of controlled substance? Almost none. Right now, looking at the list, I can't think of one. So if you want to know whether we got a problem, there you go. And so I've got 12 people in treatment court. 12. I've got the capacity for 25. That's one day. There's probably 6 or 8 new meth addicts that have to be dealt with by the system. When I say new, I don't mean new. They've got other cases, okay? But what are we going to do about that? So I leave that. I don't have an answer. Judges don't get to have answers about policy questions. That's not our job. Our job is to interpret the law and enforce the law as the legislature decides, and to use the resources that the county provides us. But anyway, it's quite disturbing what's going on. And so I just wanted to leave you with that. Sorry, it's a little bit depressing, but the reality is, it is depressing. Okay? That being said, you remember the first part of my talk, there is recovery. Recovery is possible. And the more we do to help other people get there, the more likely it is that recovery is going to be more possible for more people. And so I encourage you all to do that. And I hope I haven't gone on too long. And so that's it.
Thank you very much, Judge. We appreciate you coming. Thank you. I got to put my glasses on. Hang on. Okay, I'm going to try to be brief, and I want to thank everyone that spoke tonight. I do want to talk a little bit about what we're trying to do about the scope of the addiction problem in St. Croix County, across the nation, really. But let me just do that really quickly, cover some of the things that we're trying to accomplish here in the county to make a difference, and then I want to leave a little time here for hopefully everyone who spoke can stick around a bit for questions from the audience, okay? The two things I wanted to focus on, are just to recap, are the integration of behavioral health care with primary health care, as Dr. Anwar spoke about. That's critical. We have to treat addiction conditions the same as we treat other chronic conditions in our healthcare system. We have to treat them the same way from a professional point of view, but also from a payment point of view. People's insurance should cover this kind of health care, and there shouldn't be a stigma. There is, but there shouldn't be a stigma attached with people seeking that kind of help. The other piece that we want to address in very broad terms is the engagement with people who have this condition? How do we engage people in getting help? Sophie spoke about how certified peer specialists serve a specific role in engaging people in the helping process that didn't exist a few years ago. The other part about engagement is thinking about the way the brain works, as Pete was talking about. People's brains are affected by addiction in a way that prevents them from being able to think logically, to plan, to achieve, to go after goals, to keep appointments. Their brains aren't working properly as their addiction progresses. So what we have done historically in behavioral health is we've said to people, you have to come to this appointment on this day at this time. You have another appointment with somebody else at this day and this time. You have to go to court. You have to do this and that. And people can't. It's not that they're not motivated or they're not trying. They can't reason and logic and plan that way when their brains are affected the way they are. We have to engage people differently, and we can't design treatment systems that we think will work. We have to design treatment systems that actually do work for the population we're trying to affect. So along those lines, let me just talk about some of the things that we're doing currently, moving in those two general directions of integration and engaging people differently. St. Croix County, the St. Croix County Board awarded HHS about $2.1 million in 2021 to initiate several initiatives that we have done. One is to create 2 co-responder positions that go out with law enforcement to mental health and addiction crisis events. And those co-responders work with the person in crisis to try and diffuse the situation and help them come up with a plan that will prevent them from going to a hospital or prevent them from being incarcerated. It also frees up law enforcement to go respond to other public safety calls. We have 2 co-responders currently through that American Rescue Plan Act funding. We also have 2 community-based case manager positions. These are people that work in the community with people who might be at high risk or currently have substance use disorders, mental health conditions. And they're trying to work with people in the community where they're at so that they don't end up in a crisis situation, so that they don't end up in an emergency department or jail. We're able to financially support 2 certified peer recovery positions. Sophie is one of them. The other's vacant right now. But certified peer specialists do exactly what Sophie said, and I won't try and elaborate on that. I think she did a great job explaining. We've also started Recovering Together cafes at the Services Center just down the road. These are groups in partnership with Family Recovery Center that help parents with young children talk about in a curriculum-based way, talk about addiction, their concerns with addiction, or people they know who have it. And the effort there, in a nutshell, is to try and help families that might be struggling with addiction receive support, informal support, so that they don't end up in our behavioral health services, so that they don't end up in child protection. Trying to help these families with young kids, providing support to the parents in a way it's free. We provide a meal and we provide incentives, and there's more information about that on our website. And I also wanted to mention our partnership with Western Wisconsin Health. We're piloting an ambulatory withdrawal management service, which is a long way of saying an outpatient withdrawal management service that would focus more for the primary care physicians assessment of somebody who comes into the hospital in acute withdrawal, and better assessing people in that moment, coordinating care for them after that, and helping them come back for weekly visits with a physician and with other behavioral health professionals, Sophie included as a certified peer specialist, to start treating addiction, severe addiction, in the same way that we would treat somebody coming into the ER with chest pains. Think about the difference in those 2 scenarios when someone shows up at a hospital with chest pain and the reaction that you get from the medical staff versus somebody that shows up intoxicated. Our healthcare system has not evolved yet to the place where we have parity, but we're working towards that. And in the 30 years I've been doing this kind of work, I've seen, as looking back at least, I've seen great progress in that way. We're also using grant dollars that we receive for opioid through state opioid dollars to address opioid addiction, promoting medication-assisted treatment options for people to help with their addiction, including naltrexone and Vivitrol, which also help with alcohol craving and reducing the euphoric effect of alcohol. And we're working with schools through Prevention Block Grant dollars to provide what's the name of it is Cognito. It's a practice-based digital learning experience for students to help improve mental health and well-being in schools. And that's a new project that we're just rolling out with Prevention Block Grant dollars. I had more I wanted to say, but I know we're running a little late, and I want to leave time for questions. So again, thank you to all our speakers. Thank you to all of you for coming. This means a lot to me, and I know it means a lot to people in our community who suffer from addiction. These kinds of solutions take community efforts. They take all of healthcare, not just one program or another. So we have to all have a different and better, I think, understanding of what addiction is and how we can respond to it. But again, thank you very much for coming. Adam, do you want to help with questions? Thank you. And do you want everyone to come up here? Can everyone come up here that was a speaker and awkwardly stand with me? Thank you.
All right. Thank you to all of our presenters. Does anyone have any questions for any one of our presenters?
I know that we're talking about social services and healthcare and recovery, but the county's referendum to continue the diversion projects, and some of which I think Bob was talking about tonight with co-responders and case management, failed. What's going to happen in our county to maintain those services that keep people from being sentenced by the judge?
It's a good question, and we do have funding for those positions through the end of 2024 through the ARPA funds that we got. But in the meantime, we're always looking for sustainable ways to maintain those positions. We think our response from law enforcement has been very positive. Response from the community has been very positive about these positions being available. I work a lot with DHS around how we can either develop Medicaid benefits or Medicaid funding that sustains these kinds of positions, or find other grant funding that will sustain them. We have about 1.5 years to do that, so in the meantime, we'll continue providing those new services and always looking for sustainability. One of the problems and one of my gripes with behavioral health care is that it's too often grant funded, and you don't fund other health care that way. You don't fund cancer treatment for 2 years and then hope for the best. So we're constantly thinking about that and working towards it.
Thank you for that question. Does anyone else have any questions? Supervisor Hanson.
Thanks, Adam. This would be for Scott N. Judge, do we have a problem, or is there when somebody gets arrested and it's a meth issue, as we're identifying, or an alcohol issue, what happens to a person who's detoxing? Do we have facilities, or are they just bouncing off the walls of the cell? And what can we do better?
Well, I may not be the best person to ask because I'm not the one in charge of them down in the cell. The sheriff would probably know, but I do know from talking with people involved, we have a lot of people under the influence that are put in custody, and they've got to deal with lots of trouble. And so, in terms of detox, the most dangerous detox there is, now I'm talking with a bunch of doctors here, so I don't know if I dare say this, is alcohol. Alcohol will kill you. And so, having some kind of an ability to provide in-community detox to get these people help is definitely necessary. But how we do that now, I don't know. Bob's probably the best resource on that. But having something in county rather than having to drive folks across the state to be detoxed. The other thing is, I have had experience of, first of all, I have people in court regularly who are under the influence. My clerk will say, "Judge, you kind of smells of alcohol." And so I send them down and test them and .20, they're drunk as a skunk, but they're very articulate. Anybody who knows a good alcoholic knows, you can be a high blood alcohol and be pretty articulate, so that's kind of surprising. Lots of people testing positive for meth and all kinds of things, people in court, and we send them down, and then they go in to the jail, and that's where they are. So that's what our choices are right now. Wish we had better choices. And maybe, Bob, if you've got some ideas.
I would just say that we proposed a regional withdrawal management center here in St. Croix County about a year ago. We applied for some grant funding through DHS, and at the time we weren't funded. But that would have been a local facility that would have provided what's called medically monitored withdrawal management, would have involved physician oversight, nurses, behavioral health professionals in a residential setting for typically 3 to 5 day stabilization period, followed by ongoing care coordination, peer support, and all the other things that go after that to support somebody in recovery. Even though we weren't funded for that effort, received recently some interest from one of our legislators, a senator who is very much a proponent of developing these kinds of centers in the western Wisconsin region and around the state. Law enforcement fully supports, at least the sheriff and police chiefs that I've talked to very much support this kind of effort because it's a place where they could drop someone off who is intoxicated and they could safely detoxify without going to an emergency department. They'd be monitored and they would be supported beyond that 3 to 5 day stay with other professional wraparound services. Now, I haven't given up on this idea. Finding a facility and finding a way to staff it is a bit of a challenge, but I'm still kind of hopeful at this point because of some recent news from the legislature. So I think they are moving in a direction of trying to find funding for these kinds of regional withdrawal management and mental health. These facilities would also treat people with co-occurring mental health conditions. So we're still hopeful we can do that, but at the moment, yes, jails and prisons have become de facto detoxification centers and mental health institutions, and we're trying to change that as quickly as we can.
I'll just add a couple quick little things. A lot of people in this room know that the closest brick and mortar detox is L.E. Phillips in Chippewa Falls. But there are really, as Bob has been careful in the words he's using, there are really two kinds of things going on. So you have medically managing withdrawal symptoms, and then you have dealing with people who are very, very intoxicated. And they're two different kinds of things, and many people put them together and think of detox. So what I'll say about that is in all the EDs, in all the ERs, we deal with both of those. And so when we're dealing with is someone over intoxicated, there are certain kinds of things that can be done in an ER about that, but they don't admit somebody for withdrawal for somebody who's very intoxicated. If somebody shows up and has medical concerns for withdrawal, especially from alcohol, because it is the most dangerous, they will be treated. There's a protocol for that in the hospital to treat the withdrawal symptoms. But withdrawal from alcohol, even the most severe, if you've been drinking for 40 years, and you have very severe withdrawal symptoms that can kill you, that's medically managed, you'll get through that in 3 to 5 days. And so the withdrawal is really just the very beginning piece. And so treatment, attaching that to integration into treatment is really the key, not just withdrawal. And I'll just say this about methamphetamine. Withdrawal from methamphetamine is very different. It's mostly sleeping and eating. But the serious part of the current meth epidemic is that we have much more intravenous meth use than we did in the past. So we had a wave of a meth epidemic about 20 years ago. Then we went through opiates, and eventually we came back around to meth again. But this time it's intravenous use. And the problem with that is that people are developing psychotic symptoms. So they're permanent or long-lasting psychotics. So what happens is they end up in our psychiatric units. It's not withdrawal, but it's the effect of this epidemic. And we're dealing with that up in Amory with Health Partners all the time. And at all the other psychiatric like regions. So it's a whole different kind of medical complication from the meth epidemic.
We're starting to see in treatment court in particular, and in the testing we're doing, that meth addicts are testing positive for fentanyl. They're mixing fentanyl in the meth. Somebody is. These are not addicts that are wanting meth or fentanyl in their meth. They're just testing positive for it, and so that's hugely scary. So.
Yep.
Passing the microphone around. What other questions do you have?
So I know CPS was brought up very briefly. What are we doing to educate them about dealing with the taking away of the kids? I have personally lost my own, and it seemed as I was working with the CPS worker that it was do what you're told or you're not getting your kid back. And I think that every situation should be looked at differently based on who we are as people versus just being drug addicts.
I agree with you. It kind of goes back to stigma, but it also goes back to the dual standard for people with behavioral health conditions like addiction versus somebody that has another kind of health condition that might impact their ability to care for a child, say. I know that part of the Recovering Together Cafe effort was intended to help with this to some degree. The other hope that we have is that we can get some opioid settlement dollars to create a position within Children's Services specific to addiction care, a counselor specifically with that training, to work with families in their home and to change this. Some of the regulations even are preventive of us helping in the way we want to. So changing the way we approach this is, I agree with you, it needs to happen. And I'm sorry for your situation, but we recognize the need to improve this. We want to, and we need to change some of the rules and statutes that apply to us that are preventive of us doing what we know needs to happen. And that's not an excuse on our part. It's just the reality of the situation we're in currently and where we want to be. I hope that's a okay answer.
Are there any other questions?
Hi, I'm Chris Parr. Just off of that issue, I too have a daughter. I'm a recovering addict myself. And just, through the years of being there, not being there, and what the statistics are for kicking out addicts and alcoholics that come from addict and alcoholic parents, they got a 60% chance just genetically of being an addict or an alcoholic themselves. What is the county's stance on doing something with that, to the effect in social services, as she was saying? Is there anything that they are looking into or to make that system maybe a little bit better? I think I've been in front of Judge Norstrand for this actually, and to so I've dealt with social services and how to make it so the part it is a little bit better looked at, or what we can do for, like, I would say my daughter I'm more worried about than myself.
So you have to listen to me. But I would say what we're trying to do is to move away from a system that's punitive to people who have addiction disorders, and instead pivot to being supportive and helpful in getting them the care that they need so that their lives and their families can go on, and that a recovery is possible within the family. I understand historically how these kinds of issues have been looked at. I understand the bias, the law sometimes, and the attitudes even of professional workers aren't always in line with the current science and understanding of what addiction is. And we're not as sensitive as a system as we should be to that. If we're going to look truly at addiction being a healthcare concern, then we have to treat it as such. And we have to treat the people affected by it as having a health condition, not as being willfully deviant or willfully non-compliant. As I was saying before, the way the brain is affected by addiction creates the behavior that we see, and we have to understand that. We are trying to be more like that. It doesn't help for those that have already experienced that kind of thing, except to know maybe that we're recognizing that it needs to change.
So I can piggyback off of that with schools in we implement make it okays into the schools. So creating that awareness and education around what to look for, and then you have early intervention. And we know those outcomes come and have better outcomes. So breaking down the silos with organizations and county is what we're looking at too. So.
You know, just today, we had a graduation in treatment court. It was wonderful. And it was a person who had, didn't have his kids, didn't have his significant other, and through the course of their recovery, they got it all back and more. And I've got lots of examples in treatment court, particularly young women who have had their children removed. A lot of times, I understand this is traumatic for the children. Thankfully, most of the time, maybe not most, a lot of the time, the kids are with grandparents or other family members for a time while the parents get themselves squared away. And if that can be done positively, I'm all for it. But the other thing, there is another side to this that we have to keep in mind, and that is my job as a judge is to protect the kids. So it's a balance. If you read what I read about the 3-year-old crawling around on the floor with the meth on the coffee table, you'd have a view of that. That's not to say that's always the case, but we have to protect the kids. And then we have to develop a system of facilitating recovery for parents who want to do it. You want to know how many times I have hearings in these child protection cases where the parents don't show up? Okay, maybe it's addiction. Probably is. But if you don't show up, if you don't express a willingness to change, I got news for you. I'm not going to let the 2-year-old crawl around on the floor with the meth on the coffee table. Not going to happen in St. Croix County. So, and I don't want to be the downer, but I see this stuff, and I just want you to know what we have to do all day, what Bob's folks have to do all day at Child Protection is balance this back and forth. How do we balance it? And I got to tell you, we have a lot of protections in place to try to get kids back to parents. I have to make findings every hearing that his department is doing their job to try to get those kids back to the parents. I take it seriously. But job one for this judge is always and forever will be to protect the kids.
Thank you. And I think we have time for probably one more question.
I was just off that. I didn't know if they quite understood it. The question was what do we do for the future? You know, I appreciate everybody's answer. What do we do for the future generations that have had this? You know, we know for a fact that they are kicking out. You know, they have a good chance of being addicts. They do have a good chance of being alcoholics. What are we doing to make sure that they're not? Because it's one of the things that scares me to death is that she has to go through it. What are we doing for that if we can get to the bottom of, you know, if we can get in front of it, or what can we do?
You know, I was gonna say, you know, I had touched based on it when I was speaking about breaking that cycle. There are students out there who have seen parents go through addiction, and there are kids out there who say, I don't want to go through that. What do I got to do? What do I got to do to, you know, make myself successful? And it happens in schools, and we can refer out to county and programs, whatever it may be. There is, you know, we try to get them all, but in reality, there's not enough of us. But hopefully one day there will be.
What you're talking about is prevention, and the county is involved through public health and through different services in prevention work. But I'll just add that that's part of the role of changing attitudes and stigma as well. So that it doesn't necessarily have to be, and that if people are struggling, that they can reach out and seek treatment sooner before it becomes a more serious problem.
But that same fella today in treatment court who was having success, this is all in open court. It's not a secret, okay? I'm not going to say who it is, but the story was that his dad had been an addict. His family had been addicts and alcoholics, and he'd been raised to be that. And that at one point his son, I think faced with his dad's addiction, thought about killing himself. And that was it for that dad. He said, I'm going to change. And so he talked about exactly what you're talking about today in treatment court, that he wanted to be the break in the chain, to be different so his kids could grow up different. And I don't know if that'll happen, but I do know we had a good day, right? And so that's what I think the answer is, to have enough people achieve recovery and change so that their kids don't have to live the way you're talking about. And it's a tall order.
All right. I think that's all the time that we have for Q&A. I want to thank everyone for coming out. We did go about a half hour over. I don't know if it was all good information though. But I don't know if we still have the resource tables over there. If we do, please stop by and talk to them and get any resources that you need. We will have this. It's going to be recorded. It's going to be available on the county's website. It's also going to be available on River Channel's Facebook and YouTube pages as well. Bob, do you have anything you'd like to say?
No, just thank you for coming. It's nice to see this kind of support. Thank you.